So I'm introducing the last speaker. So it's Professor Somesh Gupta from the Old India Institute of Medical Science in Delhi, India, who will be presenting about the bottlenecks in AI.
Yeah, good evening, and I thank Christoph for bringing me in the program in the last minute as some speaker didn't turn up. So I think most of the things we already discussed about the limitations. I realize that the earlier speakers, when they were discussing the strengths of AI in dermatology, use in dermatology, but they were also discussing the limitations. So a bit of repetition here, but I'm going to discuss bottlenecks in the use of artificial intelligence in dermatology in next 15 minutes or so. So I have no conflict of interest. I am involved as a collaborator in an AI-driven image diagnostic application, but I have no financial involvement in that. And so when I reviewed the literature a couple of years ago, when we were writing our own original article for based on our experience in skin of color, I realized that most of the current studies and apps are on skin cancer detection and screening, and many of them are based on the binary classification, whether the skin cancer is there or skin cancer is not there. While it is very important to detect skin cancer, but skin cancers are relatively uncommon in skin of color. So there our primary focus is on the diagnosis of other diseases also, apart from skin cancers. And when we try to do it, uh, yeah. So when we try to develop an application with 40 diseases and later on with 50 diseases, and we try to test it in real life or real world clinical situation, then the results were something which I'm going to discuss briefly. But we developed this model based on a small number of images, that is 15,000 plus images, and eventually we tested it in 5,000 patients in 3 settings: the rural health setting, urban private practice setting, and urban tertiary care hospital. And as you can see, the majority of the patients from our own hospital, that is 3,699 patients. So what we found, this is how this app works, as earlier showed by other speakers, that it gives the probability in terms of percentage. For example, in this case, the 88% probability of this being a squamous cell carcinoma. So and it provides the top 3 and these percentages are normalized in the top 3 probability which the application shows. So but dermatology in skin of color is not about skin cancers. We have very limited number of skin cancers coming up, which is a good thing. But then we analyzed in our 5,000 patient study. So what we found is that the accuracy of diagnosis, it varied significantly among the top diseases, and it was very poor among some diseases. So now here the size of the circle determines the number of patients included in the study. So you can see that the larger circles are on the top, that is higher sensitivity, and the smaller circles are clustering on the bottom, that is lower sensitivity. So this just suggests that the common diseases have better diagnostic accuracy, because it also reflects the training data set, because in training data set also we have more number of images from common diseases. And the actinic keratosis, chickenpox, keratoacanthoma, melanoma, and tinea manum could not be analyzed because there were less than 10 cases in this. So diagnosis, accuracy of most benign conditions was good, except eczemas, which were confused with psoriasis, lichen planus, tinea, melanocytic nevi, which are confused with pigmented BCC. The basal cell carcinoma in skin of color population is most often pigmented. and the bullous pemphigoid, because the number of images was low, and the tinea manum and tinea pedis, they were confused with psoriasis and eczema. The most importantly, the malignancies were almost always picked up in top 3 diagnosis. So it's a good sign. Even in case of skin of color, they were almost always picked up in the top 3. Then we moved on and did a pilot study on biopsy confirmed cases. So when we did it in biopsy confirmed cases, these were the different patients which we could test the algorithm in. Melanoma was 2, SCC, BCC, Bowen's disease, and a large number of benign diseases with which the patient came during this period. And out of 128 patients, the single image from each patient was used, and what we found, top 1 sensitivity was 75% and top 3 sensitivity was 93%. But more importantly, the skin cancers, for skin cancers, the sensitivity was much better, that is 84.2%, and 100% for top 3 sensitivity. So this means that skin cancers are easy to detect using an algorithm. Inflammatory conditions are not so easy to detect, and they get often confused with other conditions. And another reason is that because many a times when a patient comes with hand eczema, and in one of the clinics, I explained in great detail to my resident doctors that, see, because this area is involved and the morphology of the lesion strongly suggests that this is a case of hand eczema. In the next follow-up, to all my embarrassment, he came with classic lesions of psoriasis everywhere. So this kind of confusion is also, passed on to the image database and to the machine which is giving us the diagnosis. So this is what the current scenario is: garbage in, garbage out. Because of our own confusion, our own databases, they are full of erroneous diagnostic images, and that's why the performance of AI in non-cancer conditions is not so good. Then real world evaluation is lacking, because when we try to replicate the same study among the non-dermatologist primary care physicians, there were very few takers, even at the study phase. Forget about the real world situation. So acceptability of AI in non-dermatologist, where dermatologic training is altogether absent or very minimal, is still poor. Most of the studies are in controlled settings. So this is again a big bottleneck in the current use of AI. Then validation. A systemic review found that studies that evaluate 6 algorithm-based smartphone applications, and the evidence of diagnostic accuracy was poor, and 2 of these apps were having CE marking. So it comes with a big question mark whether whatever applications are available, are they really doing the job they are claimed for? So that's a problem. And again, regulatory approval is non-existent in majority of the Asian countries, and even in countries where there is some guideline in regulatory approval of these diagnostic applications, there is much less clarity than other medical devices. So this is again another bottleneck. Then ethical consideration, the principles of transparency, justice, and fairness. And apart from that, the issue of equity. There is a possibility that the AI applications or AI use provide access to already resource rich settings, and the gap between resource poor and resource rich may further widen with the development of AI, although Christophe is working hard to bridge this gap by using African and Asian images and image database. Well, so we also try to this is now established technology, but explainable AI. So the heat map, most often provided the area of interest correctly in our own application, but there was some problem in some inflammatory conditions, and I'm not going to go into this detail, but explainable AI is the need of the hour, because otherwise the confidence of physicians is difficult to bring in most of the artificial intelligence based mobile application or smartphone application. So unless the application shows the similar images of the condition of for which the image was uploaded into the algorithm, then there will be lack of confidence in this. And so we had a simple mechanism. We had a cutoff of 40% probability. If the cutoff is below 40%, then the app would abstain from making a diagnosis. So this is a simple thing. If the probability goes down to a certain level, then app should not give a diagnosis to be on the safer side. And this is what the future models should involve. And so the no diagnosis option should always be there. And because our app is just for 50 diseases, what about the diagnosis belongs to beyond these 50 disease list? Then it has to abstain from making a diagnosis. So rejection, already the first speaker spoke on this in detail. I will not go into the detail, but it is very important that image quality has to be a good enough image for analysis in the algorithm, and rejection is so important. The AI model should reject it if the image quality is not good enough. So apart from that, incorporation of clinical evaluation. When we tried to do it, our sensitivity went down. The image, the patient metadata about the history, about the symptoms. So what we are doing now, we are building up a database in which the real-time clinical features are linked to the image. An image linked with the clinical features, for example, pruritus or the site of involvement, exposed sites or covered sites, or other features of morphology. So once we develop this database, probably the image metadata will help improving the accuracy better. So in the interest of time, I just want to show this, that how much anxiety among young dermatologists is there, particularly in India. So most often we expect that the young dermatologists, they accept technology, they are more welcoming to the technology. But what is happening here? That 9 out of 34 dermatologists or trainees, 35 years or less, they considered AI harmful for them. And 1 out of 35 dermatologists who were greater than 35 years of age, they only considered AI is a harmful thing for their practice. So young or who are still not established, they have a lot of anxiety about AI, whether AI is going to take their job. And large language models have already done so, at least of some counselors, and where the AI was found to be having more empathetic and more correct answers as compared to the human counselors. So this is going to be a big challenge for AI in future. So we should always encourage young people to adopt the new technology, also the peripheral doctors and primary care physicians. It is not man versus machine, but it is man plus machine. Thank you very much for your attention.
So thank you so much for your talk. We have seen the potential of artificial intelligence to augment the clinical practice. We have seen a lot of opportunities. There are a lot of opportunities in dermatology, but there are more opportunities even when we put this technology also in primary care. But what is very important is that before we are there, we need to understand how this technology pairs in the clinical practice and pairs with physicians. And this is why it's very important to have these opportunities of collaborate and educate together on the use of technology in the clinical practice. So that is all. Thank you so much. And I think we have some coffee outside.
I think you should grab it while it's still there. So I encourage you to go for coffee for the next few minutes, and then we'll be back for the next session. Thank you all.